In today's lecture, I'll be talking about atherosclerosis as part of our discussion of innate immunity and inflammation. Atherosclerosis is the process that leads to arteriosclerosis of middle to large arteries. Arteriosclerosis is the thickening and hardening of the arterial wall, and you can think of atherosclerosis as the cause of arteriosclerosis. In essence, atherosclerosis is the buildup of lipid in the arterial wall, and it is the major cause of cardiovascular disease, heart attack, and stroke. This process contributes to the death of nearly 20 million people worldwide annually. The major consequences of atherosclerosis are ischemic heart disease, stroke, and peripheral vascular disease. It is still unclear what events initiate atherosclerosis, but it is generally thought to be triggered by injury to the arterial endothelium and the ensuing inflammatory response. Smoking is a risk factor for atherosclerosis. It is thought that toxins associated with cigarette smoke enter the bloodstream and cause damage to the endothelial cells. Hypertension is also associated with atherosclerosis. Increased pressure on arterial walls can lead to injury. Diabetes is a risk factor. Atherosclerosis accounts for 80% of deaths among diabetic patients. High concentrations of low-density lipoprotein, LDL, or low concentrations of high-density lipoprotein are also associated with the development of atherosclerosis. As we will see, cholesterol, and especially LDL, plays a pivotal role in the progression of atherosclerotic lesions. Atherosclerosis might also be the result of an autoimmune response against the endothelium. Recent studies have implicated antibodies that bind to proteins found on the surface of endothelial cells in the pathophysiology of atherosclerosis. Other non-traditional risks for atherosclerosis include infection, insulin resistance, and periodontal disease. So we've got a lot going on this slide here, but let's walk through it. This slide shows us the general progression of atherosclerosis following endothelial injury, and these processes take place over a long time, often years. Remember the three layers of the artery. The tunica intima borders the lumen, the site of blood, and includes the endothelium. External to the intima is the tunica media, where smooth muscle cells are found. And external to the media is the tunica adventitia, the outer covering of the blood vessel. Atherosclerosis takes place within the intima layer, right here. Starting from the top left, we can see the events that occur following endothelial injury. Damaged endothelial cells release inflammatory cytokines. Platelets adhere through the clotting cascade, and lipids, especially LDL, accumulate in the intima. Circulating monocytes adhere to the damaged endothelium via adhesion molecules expressed on the damaged endothelial cells. These monocytes migrate into the lesion of the intima. There, the monocytes differentiate into macrophages, which then secrete cytokines, enzymes, and toxic oxygen radicals as part of an inflammatory response. The macrophages also phagocytose the LDL trapped underneath the endothelium. These lipid-laden macrophages are called foam cells because of their appearance under the microscope. Macrophages also produce growth factors that induce the migration of smooth muscle cells from the tunica media into the intima, as shown in the top right. The smooth muscle cells produce a fibrous plaque of collagen that eventually hardens, often becoming even harder through the accumulation of calcium. The plaque expands into the lumen of the blood vessel, restricting blood flow. In some cases, the plaque ruptures, triggering platelet accumulation, through the clotting cascade and the formation of a thrombus. The thrombus may block the vessel, causing ischemia and possibly even infarction. Three types of lesions are associated with atherosclerosis: fatty streaks, fibrous atheromatous plaques, or just fibrous plaques, and complicated plaques, or complicated lesions. Fatty streaks result from lipid-filled macrophages that have accumulated in the intima. The lipid content of these lesions causes them to have a yellow color. As the inflammatory process progresses, these fatty streaks grow. Eventually, the macrophages of a fatty streak will attract the smooth muscle cells which cover the streak. The smooth muscle cells secrete collagen, hardening the lesion to form a fibrous plaque. Fibrous plaques can collect calcium, causing further hardening and protrusion into the lumen. If a fibrous plaque ruptures, the ulcerated lesion is now referred to as a complicated plaque or complicated lesion. A complicated lesion is associated with platelet adhesion, clotting, and thrombus formation. This slide shows us the gradual growth and the changes that take place in a plaque over time, often over years. We see that the plaque grows as lipids, macrophages, and smooth muscle cells accumulate, narrowing the blood vessel. Coronary artery disease occurs when a plaque blocks blood flow to the heart, depriving the heart muscle of nutrients and oxygen. If a coronary artery is sufficiently occluded, ischemia occurs. The function of the myocardium is impaired by the lack of blood flow. If a plaque ruptures, or a plaque grows to fill the lumen, the whole blood vessel may be blocked, resulting in irreversible damage to the myocardium, infarction. This condition is known as acute coronary syndrome. If atherosclerosis affects arteries that feed the brain, the carotid arteries, cerebrovascular disease may result, possibly leading to stroke. When atherosclerosis affects the limbs, the result can be peripheral artery disease. Symptoms associated with peripheral artery disease include pain with ambulation, also called intermittent claudication, loss of pulse, and changes in skin color of the affected limb. Here we can see an artery in cross-section. The intima is this gray layer along the right, and the lumen, where the blood flows, is in the middle. The yellow material here contains the foam cells, lipid, and smooth muscle cells and extracellular matrix of the plaque. In this slide, we see more pictures of atherosclerotic plaques. In the top left, we see an H&E staining of a cross-section of artery containing a plaque. The lumen is the open hole in the middle, lined with endothelium, and the plaque stains with a dark purple color. Here is all the lipid macrophages. Note that there is a layer of smooth muscle and endothelium that covers the plaque, separating the lipid area from the blood. In the bottom left, we see a longitudinal section of a carotid plaque. Note the smooth surface of healthy endothelium in yellow compared to the ulcerated plaque that is darker and rough in appearance. In the upper right, we are looking at a plaque with H&E staining under high magnification. The crystal-shaped areas that lack staining represent sites of cholesterol, LDL accumulation. The processing of sections for H&E staining actually dissolves the lipid that's normally found in these areas, leaving these empty spaces that are commonly referred to as cholesterol clefts. In recent years, it has been realized that the atherosclerotic plaques that they vary in composition and consistency, and that the structure of a plaque determines how likely it is to rupture and form a thrombus. In essence, treatment of preclinical lesions is based on stabilizing plaques to prevent rupture. A stable plaque generally is very fibrous and has a thick fibrotic cap with little lipid in its core. In general, a harder plaque is less likely to rupture than a soft plaque. Nonetheless, a stable plaque still blocks blood flow, and in men accounts for 70% of angina cases. The primary goal of treatment is to restore blood flow to the affected area. Treatments include medication, smoking cessation, weight loss, and exercise. Should a stable plaque occlude a coronary artery, though, infarction will occur. The body does have compensatory mechanisms for dealing with blocked arteries. The formation of collateral blood vessels that restore blood flow to tissue. As you might expect, however, collateral arteries are not perfect substitutes for the original artery. In contrast to a stable plaque, an unstable plaque has a greater risk for rupture and thus hemorrhage and thrombus formation. Unstable plaques are characterized by a soft, lipid-rich core with a thin, fibrous cap. Potential triggers of plaque rupture include the activity of macrophage enzymes. These enzymes, often matrix metalloproteinases, will digest the collagen and elastin laid down by smooth muscle cells in the cap. This process renders the plaque more susceptible to rupture. As we've discussed, a plaque that ruptures results in thrombosis and platelet adhesion. Complete occlusion as a result of plaque rupture may lead to ST-elevated myocardial infarction and sudden death. Treatments include statins and low-dose aspirin. Since LDL cholesterol plays a central role in the progression of atherosclerosis and coronary artery disease, maintaining healthy levels of LDL is important to reduce disease risk. For both men and women, LDL-C cholesterol is the major factor for coronary artery disease. It is recommended that LDL levels should be less than 100 milligrams per deciliter in the general population, and less than 70 for secondary prevention, and those who have had, for those who've been diagnosed with coronary artery disease. Diabetic patients over the age of 30 are also considered at very high risk for atherosclerosis. Lowering lipid levels and controlling blood pressure is critical to reducing risks for atherosclerosis. The clinical manifestations of atherosclerosis are narrowing of the blood vessel, the artery, possibly resulting in ischemia. Plaque rupture results in vessel obstruction. This can result in thrombosis and formation of emboli as a result of damage to the vessel endothelium. We haven't talked about much here in this particular lecture, but atherosclerosis can also result in weakening of the arterial wall. Such weakening can eventually lead to aneurysm, in which blood ruptures out of the arterial wall into the local tissue. Since atherosclerosis is a disease that progresses over years, it is often a difficult disease to treat. Patients may be asymptomatic, but risk factors and family history may indicate that they should start treatment before there is any evidence or any sign of disease. The nurse's charge commonly with atherosclerotic patients is to support these patients, educate them about the disease, and probably most importantly, is to really push for changes in behavior. It is not uncommon to find that patients do not wish to take expensive drugs like statins that have several side effects. And therefore, a nurse's job is to support that patient in maintaining their healthy lifestyle and getting them to understand the risks that are associated with behavior, family history, um, uh, and providing them with sufficient information on the pharmaceutical treatment of disease. Thank you for your attention, and I'll talk to you soon.